Welcome, everyone, and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. For the record, please note Aaron Kelly, representing Deputy Mayor Ann Williams-Eisen, Dr. William Fisher, representing Deepa Avula, and Karen St. Hilaire, representing Molly Wasau Park, all in a voting capacity. During the executive session, the board received and approved oral and written governing body submissions from New York City Health and Hospitals Metropolitan, received and approved semi-annual governing body reports, written submissions from New York City Health and Hospitals Woodhull and Bellevue. The board also received and approved semi-annual governing body 2022 performance improvement and evaluation plan written submission from New York City Health and Hospitals Segundo Ruiz Belvis Gotham Center. And the governing body also reviewed and approved the governing committee's proposal to appoint Ivelisse Mendez as the Vice President of Chief Diversity, Equity, and Inclusion Officer. So congratulations to Ms. Mendez. I'm not sure if she's still Then moving on, next on our agenda is the adoption of the minutes for the Board of Directors meeting held on June 29th, 2023. Are there any questions, comments, or suggested changes to the minutes? Can I hear a motion to accept these minutes? Motion. Second. All in favor? Any opposed? Okay, the motion carries and the minutes are adopted. So since we began the process of approving contracts prior to Vendex approvals, there are two items on today's agenda requiring Vendex approval, and both have that approval. There are three items from previous board meetings pending Vendex approval, and since we last met, no approvals were received. We will continue to notify the board as outstanding Vendex approvals are received. Moving on, we have two resolutions. The first is Dr. Calamia from NPA.
Thank you. Authorizing the New York City Health and Hospitals Corporation, the system, to execute an agreement with Rapid Reliable Testing, LLC, doing business as DocGo, Inc., for time-sensitive and short-term clinical and support staffing at any variety of emergency response alternative care sites, ERACs, during a period of an emergency response as directed by the system's president, with appropriate notification to the board. The initial term shall be 3 years with 2 one-year options to renew, solely exercisable by this system. Contract shall not have a pre-established not to exceed amount. Presented to the MPA on 7/10/23 for a presentation to the full board.
Thank you. Great. Dave, thank you.
Hi, everybody. Good afternoon. So for those of you I have not met, my name is Dave Silvestri. I was the third listed one on that title slide. I'm an emergency department physician. I work a day a week at Lincoln in the South Bronx. And the other days a week, I am a senior assistant vice president in the Office of Quality and Safety under Dr. Way, overseeing emergency management for the system, in addition to a few other areas. So it's a pleasure to meet you. I hope we get to meet a little bit more in depth in the future. So I think I'm always someone who I think likes short and sweet take-home points. The tagline of today's brief summary is something I think most of you have probably heard before, which is that it's far better to stay ready than to get ready. Mm-hmm. So if you're to remember anything, that's really the gist of this. So as you all know, as you all probably know, if not, we are as a system required to staff, to provide clinical staffing for up to 7 special medical needs shelters, SMNS shelters, as part of the city's coastal storm plan. Now, again, an SMNS shelter, a special medical needs shelter, is a sort of a fancy way of saying it's an evacuation shelter for people who have special medical needs. These are not hospitals. This is not acute care, right? Patients who need acute care belong in acute care hospitals. So, this is for people who have subacute care needs, people who are living in the community for one reason or the other, who are interrupted in receiving their health care, in many cases home health aid or home care nursing services, and need to receive those services in an alternative care site. So that's the Special Medical Needs Shelter Program within the New York City Coastal Storm Plan. And again, New York City Health and Hospitals is required to provide clinical staffing for those shelters, up to 700 to 105 shelterees per facility, and those generally occur in facilities like school gymnasiums, etc. Now, when I say clinical staffing, I mean potentially multiple different titles: physicians, nurses, nursing support, home health aides, etc. are sort of the three major ones that we talk about. Now, while that's sort of an explicit ask and requirement for health and hospitals through the Coastal Storm Plan, we also know within emergency management that there are many other potential scenarios where we may also have to stand up SMNS-like alternative care sites. So that's why we've come up with this term, emergency response alternative care sites. Effectively, it's a similar type of facility as I just described for the SMNS shelters, but it's a term that would allow us to, or that we can think about across any potential hazard, not just a coastal storm. So historically, when we've tried to staff these SMNS shelters in large-scale hurricane events, Irene and Sandy most notably, we've tried to use existing health and hospitals outpatient staff, largely our hospital ambulatory staff and our Gotham staff. As you can imagine, this comes with a considerable amount of logistical constraints, and it's effectively one of the major recommendations coming out of Hurricane Sandy is that we don't do that moving forward, that we have a sort of a more dedicated solution for those clinical staffing needs. We, as a result of that, are seeking to enter into contract for emergency response clinical staffing for these sites. We do not have an existing a contract to fulfill these staffing needs at the present. Next slide, please. So just to go through some nuts and bolts, as we just sort of alluded to, in the event of an emergency response need, whether it be a coastal storm or a different type of emergency response need, City Hall or New York City Office of Emergency Management may activate the deployment of emergency response alternative care site services. The proposed contract activation, to be explicit, would occur by New York City Health and Hospitals President and CEO upon either the city request or after declared emergency at the city, state, or federal level, with appropriate notification to you all board. And the activation presupposes that there will be either city funding by way of an MOU to cover contractual costs or anticipated reimbursement through FEMA or some combination thereof. So take-home point, another one to kind of underscore, we do not anticipate operating any sort of additional operating costs. There's no operating costs anticipated to New York City Health and Hospitals beyond those reimbursed again through existing city MOUs that would be established or through, again, kind of emergency disaster reimbursement at a higher governmental level, unless approved explicitly by again, the board. Next slide, please. Just kind of get a little bit into the weeds here on some of the finances. So again, there are emergency, whether it be FEMA or other levels of funding through, again, governmental sources. So depending on, again, the incident magnitude scale, there may be a declaration at one of those levels triggering funding. Our SMNS agreement with the city already comes with that existing, designated funds. And for non-coastal storm, non-SMNS, but for SMNS-like scenarios, again, we would conjure up MOUs as necessary for those specific needs as they arise. And I kind of mentioned, but just to make explicit, it's not either or. There can be a combination of city funding in conjunction with federal funding. In fact, that's as members of the city, all right, that's actually how we prefer it. Cost structure, we talk about a lot of variation, a lot of uncertainty here. How do we think about defining costs for this particular vendor? So the cost structure, one of the most important things is for us to make sure that we predetermine rates, right? We don't want to find ourselves subject to market fluctuations in the middle of a major disaster. So the nature of the contract is that we would have predetermined rates, not subject to those fluctuations. Those rates themselves are really a function of three things. What type of clinical staff are we talking about? Obviously, physician, nursing aid, different rates. How quickly are we going to get them to our site? One of the major things we'll talk about in just a second is that we need potentially for individuals to be present within 24 hours of activation. And then how long are we going to actually commit to needing these individuals? Is this a 2-3 week need versus a 2-3 month need? And that potentially changes how those rates play out. The number of staff, or the contract is designed flexibly such that the number and distribution or composition of that staff would be able to match the specific needs, again, of the emergency. So there's, again, that built-in flexibility. And an important point here on credentialing is that the vendor does the credentialing for us. Next slide, please. When we put together the RFP, we won't go through all the points on this slide, but just a couple of things that were really priorities for us is to find a vendor with a significant amount of experience in this space, not just experience doing clinical staffing, but experience doing rapid clinical staffing. And then again, sort of related to that, another major point was for us to really find a vendor that could provide us assurances on being able to deploy staff within a 24, 48-hour turnaround. We also wanted to make sure that we leveraged the broad subject matter expertise within our organization. So our RFP committee included members from finance, quality and safety, risk management, nursing, patient-centered care, community care, ambulatory care, and M&PA. Next slide, please. It was a very rapid procurement process. We wanted to have as much taken care of before we got into the height of the current coastal storm season. We went from approval to enter into RFP back in mid-April through to receiving 10 proposals in the beginning of June, scoring those proposals, landing on 3 top firms by mid-June, hearing those firms out, and then finally landing on our top choice, Rapid Reliable Testing, doing business as DocGo, on the 23rd of June. Next slide, please. DocGo has met our requirements for MWBE. Their proposal is on the slide here. Next slide, please. Those of you who have heard of DocGo, that it's not a new name. They do, and they have worked with health and hospitals in the past. They have helped support a number of our mobile care delivery operations through the COVID pandemic and play a significant role within our response to the asylum seeker crisis as well. Their performance has been commendable during that time, and you can see that in their performance evaluation here. Next slide, please. Just in summary, we, Central Office of Emergency Management, we are seeking approval from you all to enter into contract per the summary I've just laid out with DocGo, with Rapid Reliable Testing, to provide clinical staffing in the manner I've described in the emergency response alternative care sites. Just to again reiterate, no costs would be incurred by health and hospitals if services aren't activated, and services would only be activated again by our president and CEO with appropriate notification to you all, the board. Expenses in that case would be covered by City Hall, again, a higher governmental agency, FEMA, for example, or approved explicitly again by the president, CEO, and board. Our hope, just around the corner, we may not quite make it, but we're not too far off. Our hope was to be able to enter a start date of August 1st. That was the initial hope, but again, we were told that it was way optimistic, and we'll honestly bank it if it's a few weeks after. If it's a few weeks behind, we'll call it a win still.
Thank you for the presentation. Question.
Yeah, I think I just woke up that last bit. My attention.
Yeah.
I mean, this is a wonderful addition to what we talked about some of this.
Yes, absolutely.
Just before we convene today, it is really good to keep talking about elevating emergency workers ready to go or whatever. I think that it's obvious we're going to be living with emergencies for a while that we didn't have before, maybe some which are bigger than those we've had. And it's a good way to get people involved in the profession. I always say don't give up on the teenagers.
Yeah.
Yeah. Got to make it possible for them to come on in. The city keeps growing, and we hear different incidents from time to time, and I just feel that there's not enough people there for people when they're in trouble. Whether it's some kind of assault or whatever. But I think this is a good plan. And what are we calling ourselves then?
What do you
think?
We should have an institute for this. We're training and doing all of it, are we not?
Well, with this particular vendor, we would be doing, once we lock the vendor in, we would be doing a significant amount of sort of, again, kind of planning, exercising, drilling, again. So it's not just like, okay, we got a contract and let's go shake hands 2 years down the road, but that we actually know each other. We know what the plans are. Yeah. So it's more turnkey, you know, God forbid, should such an incident occur where we do have to stand up such a.
Great. Thank you.
Dr. Morse.
Yeah, thank you for the presentation. I was, to your point, actually, about some of the planning and some of the collaborations that can happen even outside of activation of this contract. I was curious if you could speak a little more to how the contractor would manage, or if H&H would manage interpretation services, just knowing that is such a central part to an equitable emergency response. And is that covered in this contract? And curious about that function.
Yeah, it's actually a detail that I don't have all of the information about. I do have a colleague here who works very closely with DOCO. You know, obviously we have an hospital to be able to furnish them with the ability to use our 200 plus language of support. Do you know if DOCO provides their own native? They have their own services as well. So thanks.
Excellent. Dr. Calamia.
Yes, just a question relating to the nature of emergencies, unfortunately, is they're urgent, and sometimes there are multiple providers that are going to need services like this. Are we getting to exclusivity? Are they our exclusive provider in these circumstances, and vice versa? You know, if there are multiple providers in need of these types of services, do we have some
priority?
First, yes, priority in that setting.
So one of the biggest things I think going for us is that we do have an extensive relationship with this particular vendor in other areas as well. And they've actually demonstrated that despite all of the demands that we've actually observed in the last few years, we've actually not had any concerns with them. So to be honest, I think that the best indication of the future for again, this particular situation is the past. So no significant concerns there from us. Just as an example, they in the height of COVID, they were able to deliver over 1,000 plus clinical staff within a 24-hour period as part of an overall response need. So,
Sally?
Does this meet fully the recommendation that was made to you during the last circumstance? You said that we weren't fully prepared last time the recommendation was made. Was it a fully detailed recommendation, or just be better prepared next time?
Yeah, so when we tried to use our own clinical staff to staff these shelters, which in some cases are 24/7 shelters, it introduces a lot of potential challenges. For example, right, if you need to staff a shelter with outpatient staff, but the outpatient staff's clinic is still operational, right, what do you do, right? That just means you have to then cancel or reschedule appointments unnecessarily. If you have to do 24/7 staffing, but these individuals don't typically work 24/7, what do you do? So again, I think it was appropriate at the moment, but again, the recommendation was that sort of a more targeted, dedicated workforce be identified for these particular sites. So this significantly delivers on that.
Thank you.
Any other questions or comments? Thank you, David. And I will call for a vote. All those in favor?
Aye.
Any opposed? No. So the motion carries. Thank you very much. Contracts approved.
Thank you.
Next, we have another contract for item number 7.
I'd like to recuse myself from this motion.
Thank you.
Thank you.
We'll wait for Dr. Calamia. Okay, so this was in Finance Committee. Item number 7, authorizing the New York City Health and Hospitals Corporation, the system, to execute an agreement with Optum Insight Inc., Optum, for contact center services for an initial term of 5 years with 2 one-year options solely exercisable by the system in an amount not to exceed $145,593,595 for the entire contract term. This was presented and discussed at Finance Committee on July 10th, 2023, and approved to bring to the full board. And I think Cendrix and Dr. Long are going to present.
Thank you. Good afternoon, everyone. My name is Lisa Hendricks. I'm a Senior Assistant Vice President within the
Be
ambulatory.
okay if you sat at the end of the table so we could see you?
Can we sit? Yeah.
Lisa, just, yeah, move. You'll just see better and you'll project.
Leaning across. Good afternoon again. Senior Assistant Vice President. I'm in the Office of Ambulatory Care and Population Health, and I oversee the contact center. I've been here with Health and Hospital for just over 3 years. Lucky enough to join the system right at the height of COVID in March of 2020. We're coming here today to discuss our new contract with a vendor. I thought it might be helpful to just take a moment and ground everybody in the services that we provide at the contact center and the services that our current vendor is providing, and also how the calls come into the contact center. So today, the majority of the calls that we receive are from our patients calling 844-NYC for NYC, our branded contact center number that was put in place a couple of years ago. We also have press offs from the separate facilities for patients who call Queens Hospital, for example, and press the appointment option on the IVR. Those calls will roll over to us as well. And we do some rollover from practices and clinics should the front office staff be unavailable. We want to ensure that the patient's call gets answered. We have a small internal staff within the organization that sits in Bellevue today. The majority of our calls that we cannot handle immediately roll over to our current vendor, which is Change Health. They support not only these calls, but then they also have direct lines that they support for the health system. We deliver and receive approximately in 2022, 2.6 million calls. So many calls each year. Our contact center is open 24/7, 365 days. And some of the calls that we take are patient appointments, prescription refills, clinical questions. We provide support to after-hour clinicians, folks that are calling in, wanting to speak to the after-hour clinician, and then just general questions about health and hospital location, hours of operation, lab hours. Next slide, please. So in addition to our contact center proper, this vendor is also providing the following services. They've stood up a contact center for NYC Care. They do dental appointments for Kings County, Gouverneur, Metropolitan, and Queens. They've set up a contact center for World Trade Center. At Lincoln, they do live outbound appointment reminder calls. Jacobi, they do some robocalls, SMS appointment reminders. They do a resident satisfaction survey, and they also have some on-site pre-registration support. For Jacobi and NCB, they provide after-hours support for their oncology and HIV clinics. And then for community care, they provide an after-hours messaging service for the home health group. So very diverse across the system. It's common in health systems to have a centralized contact center, whether that is completely outsourced, a combination of internal and outsourced like we are today, or an internal team. Most of those decisions are determined by the size and the volume of the health center. As I said earlier, with our call volume increasing to 2.6 million calls in 2022, plus we anticipate some year-over-year growth, and given the success of the contact center, more of the facilities and practices are asking us to take on their appointment work, freeing up their front desk staff and nursing staff to help patients right there in their practices. We anticipate and we're projecting to have over 3 million calls for fiscal year 24. Currently, we've got a 7-year contract with Authority through September of 2023 with Change Health. Our current fee structure is a combination of charge per minute of talk time and then charge per minute of transfer calls, plus a service charge for different levels of services that they provide. On average, between 2020 and 2023, The average yearly expenditure was around 21 million. This was impacted in 20 and 21 by COVID and our greatly reduction of calls because of halting some of the services. But as you can see in 22 and 23, we were getting closer to that $25 million a year mark. With this contract over 5 years, with all of the services remaining exactly the same, we're anticipating about $29 million. Okay. The contract will secure a partnership with a vendor that is experienced and knowledgeable, has been successful in their operational support as well as staffing, and comes with a proven track record. With the RFP and contract, we're looking to add more structure and rigor to our current contact center services, not just the contact center proper, but putting some rigor around all services provided by one vendor, with oversight coming from my senior leadership team. Next slide, please. The scope of our RFP that we issued was based on use cases across the system, plus the experience that we had in the contact center, along with the experience, the 20 plus years of experience from myself and my senior leaders on my contact center team that have experienced both as the client and as the vendor supporting a client. Our key scope of deliverables were based on service level agreements, key performance indicators, reporting, the technology platforms, offerings, different things that could be integrated, as well as security and robust operational support, which is critical. Desired outcomes of the RFP was to establish service level agreements that met responsible budget requirements. We wanted to have performance penalties in place should the vendor not be able to perform to the KPIs. We wanted to make sure that we had a fee structure of either per minute or FTE, which is the most cost effective for this type of work. And then we wanted to make sure that we were organizing all of the contact center services throughout the system under our contact center organization so that we had oversight and could keep the vendor in line with their performance agreements and different statement of work. Vendors typically performing in this space are Optum, Change Health, T-Tech, Teleperformance. We don't anticipate that there are any labor impacts to or role changes to our internal staff. This vendor is an enhancement to the staff that we have. And we anticipate additional EITF's staff supporting transition to a new vendor. We also are using this opportunity with the new vendor within the first couple of years to take and transition more ownership to the internal contact center staff, which is bringing the vendor and the vendor resources onto our technology platforms, which gives us a lot more control. It's much easier from a security perspective for onboarding and offboarding resources, as well as putting our internal team in control of how training quality performances are delivered. Through the first 2 years of the contract, we will establish milestones, transition milestones in partnership with the EITS team, and as we implement a technology transition. Okay. Next. Our RFP criteria, again, we were looking for a minimum criteria of at least 10 years in business. They needed a footprint in healthcare with a proven ability to scale a high volume contact center. And then we were looking for minimum annual revenue of $100 million. We went ahead and removed the revenue requirement for MWBE firms. Our substantive criteria, 15% on cost, 10% MWBE, 20% technology, 25% operational support, and very critical 30% on staffing and scalability. If we don't have people to answer the phone, we can't service our patients. We had representation from across the system participate in our evaluation committee, along with senior leaders in the contact center. We had chief information officer, our compliance staff was involved, our EITS with our United Comms and Voice over IP, as well as senior leaders from our revenue cycle, as well as administrative leaders from both Gotham and our acute facilities. Next slide, please. So an overview of the procurement. On May 2nd, we had an application to issue request for proposal was approved by CRC. On May 10th, we posted our RFP to the city record. We sent direct invitation to 6 vendors, which included an MWBE prime candidate. On May 16th, we had a pre-proposal conference. 25 vendors attended. On June 8th, we had 9 competitive proposals received by the due date. On June 15th, our evaluation committee conducted the first round of scoring the competitive proposals, which also included an MWBE vendor. The top 3 firms were shortlisted. On June 20th and the 23rd, all 3 firms conducted virtual presentations and were interviewed by the evaluation committee. On June 26th, the evaluation committee debriefed and submitted final scores. Optum Insight was the highest rated proposal. Thank you. A little background on Optum. They've been in business for over 30 years. They are a major player in the healthcare space, serving over 300 million consumer calls. We've listed a few of the similar work that they're doing with AARP, NYU Langone, the Arkansas Department of Human Services, and some others. We've had the unique opportunity to work with Optum. We had a 2-year contract with Optum. They provided support and staff for our New York City Chest and Trace Contact Center. And within the contact center, they quickly scaled up to over 3,000 monitors. We did case investigation and monitoring of close contacts of positive cases. They consistently met the requirements of connecting with and speaking to the appropriate cases, positive cases, and close contacts within 48 hours. So we've seen that they've got a proven track record. We've seen them in action. With Optum recently making an acquisition of Change Health, which is our current vendor, we get to have a little bit of the best of both worlds. One, we get to keep tenured, high-performing staff who have an extensive knowledge of our program. They have staff that has extensive knowledge of our technology and integrating our technology, so there won't be any additional cost from an EITS perspective as far as migrating and integrating their technology. In addition, they will be bringing a new technological platform that allows us to open up and offer some omni-channel communication experience with our patients, like web chat, when we're ready to do something like that in the future. They will be bringing in artificial intelligence to do a little call deflection for us, which will be a cost savings for us. And Optum has a very close partnership with Epic, so we see the potential of maybe even doing some more integration that can improve the patient experience, as well as reducing our overall cost. Next slide, please. Optum will commit within their contract to a monthly penalty percentage should they not meet the key performance indicators. Some of the key performance indicators would be abandon rate, average speed of answer, overall service level. We will have a bilingual hiring requirement where 30% of the staff will be certified in speaking and writing Spanish. There will be a minimum to the AI call deflection. So that'll be established within the contract to determine what percentage of call types we can deflect. Those would be something like hours of operation, location, something that didn't require patient authentication or Epic integration. Optum will also be meeting the language needs of our patients. Our IVR system today is in 9 languages, but we know we serve many more than that. So they will have language interpretation services for the staff. And our cost structure will be a combination of an FTE and a per minute rate, along with the proposed AI deflection. Typically in this industry, call deflection could be up as much as 50 to 60%. We're going to set a conservative goal of 30%. We're going to dig in and make sure that we can, commit to that. And again, those are calls where a patient can self-serve and immediately get the information that they need, very general information, nothing that takes place with an authentication of patient information. Next slide. The MWBE component percentage, it was determined after analysis that this contract was assigned 30%, spread across a diversity of recruiting and staffing, information systems and automated messaging or implementation. We go to the next slide. Optum is proposing 36%, so they are exceeding our 30%. They are diversifying and using several different staffing partners in order to staff across the diversity that we serve as our patient base here at Health and Hospitals. Next step. So the Office of Ambulatory Care and Population Health is seeking approval to enter into contract with Optum Insight to provide contact center services at a not to exceed amount of $145,593,595. We anticipate a contract start date of October 1, 2023. The terms of the contract are 3-year term with 2 1-year renewal options for a total of 5 years.
Thank you. Ted, do you have any comments?
No, we covered
it. I do have an appendix slide, one more slide that shows the projected 3 million calls.
Okay, that's good enough. Any questions?
I'd like to have kind of a before and after scenario, like before Lisa and Optum 3 years ago, where like a sense of kind of how many were our staff members, how was Change Health staffed,
yeah.
And I guess based on some of your learning from that prior experience, how did you formulate the RFP to either change practices, add practices, meet unmet needs or needs that were identified and you couldn't meet under the old vendor? I'd really like to get a sense of before and after.
And can I just quickly,
yeah.
just to give Lisa some credit here, because it's a great question, Sally. Lisa can tell us about, since she's been here with her decades of experience, the improvements we've already been able to make with speed to answer the phone, with abandon rate, which we all know were big problems before Lisa came. So she can tell us about what she's been able to do so far, and just imagine what more we could do with a vendor like this.
Yeah, we were, coming in, I think we were in a position of flux. The contact center was being centralized. It was moving away from the facilities into a centralized group. It was very much borough-based. It was a small internal staff. There was a lot of dependence on the vendor. There was a lot of the vendor making decisions, a lot of ownership on the vendor side, high wait times, high abandon rates, really not a lot of checks and balances in place. With me coming in and, with having 20 years experience, mostly on the vendor side, I've been the vendor. I've been the one required to perform, the one to answer the tough questions, to put the, action plans in place. So I know what I expect as someone who's serving a client. I know what I would expect to deliver, and I know what I expect a vendor to deliver. And we weren't close to even being there. And so a lot of the work that I did when I first came in addition to working with New York City Test and Trace, was really focused on vendor and performance improvements. Also taking a look at, how can we best work with the team that we have? So moving away from a borough-based call routing where we would have agents assigned to Brooklyn, and that Brooklyn agent would take a call for a specialty appointment, a women's health appointment, a peds appointment, an adult primary care. That's a lot to remember, and we don't necessarily have standard practices across our facilities. So, where Queens might want it different than Elmhurst, might want it different than Bellevue. So there was a lot for one person to know. And it didn't give you the opportunity to really cross-train and cross-utilize. So one of the first things I did was to call, route, and train and deliver the calls based on service. We had a adult primary care appointment where we had adult primary care experts. All of our agents knew how to do adult primary care appointments across our system. Same thing with women's health, specialty, pediatrics. And that allowed us to answer more calls quickly and then cross-train agents. So when we had a pickup in women's health calls, we could move some cross-train adult primary care, which we were handling, over to women's health. So just doing that simple, it sounds simple, simple, very complex. But just doing that one change made a big difference in how we answered the phone. And could we answer the phone? And could we handle the patient? That was one thing. Understanding that to be truly successful, we have to own, we health and hospitals. This is our epic. These are our patients. We should determine how they should be served. We should determine the quality scorecard. We should determine the processes. So I was I've got approval to build out the infrastructure that we need. So I've spent the last year just building the internal infrastructure to allow us to take ownership, to allow us to take more control, to hold the vendor more accountable. And, recently, we've had our good periods and, we've had some tough periods, to be transparent, but the majority of the time we are answering across service lines. And I've established reporting. I get reports, and so does my team, every 10 a.m., 12 a.m., 2 p.m., 5 p.m., and first thing in the morning for the end of the day. I know by service line, by skill, how quickly we've answered every half an hour, how long anyone's waited every half an hour, what the average handle time is every half an hour. And that's what I hold the vendor accountable to. When I see an interval where anybody's waited over 30 seconds or our abandoned notes over 5%, I'm on the phone with the vendor, or my team is on the phone with the vendor. That's the commitment that we've made and the expectation that I have of the vendor who's serving us. So our answer time is Monday's always a little busy day for us. So we might be exceeding the 30 seconds, but we're averaging around 20-second wait time when you call into our contact center. And even if the call is rolled over from a facility or from a practice. So hiring the right expertise, setting up a shared services group. Shared services covers training, quality, workforce management. Workforce management and scheduling are highly complicated. We need to know that we've got the right people available, the right number of people available at that time to answer the call. So it's managing lunches and breaks and training, but it takes an organization. And I will say that from the experience that I had with Optum managing schedules for 4,000 people to ensure we were meeting the criteria and the performance of the tracing contact center, they are world-class at ensuring that we've got the right schedules and we've got the right staff. And that's where it all starts with.
So let me ask you, Lisa, they're world-class. They seem to have a very competitive proposal. They brought new ideas, use of A1, they've got bilingual hiring, they're good with Epic, and yet you have language about looking to transition and lessen our dependence on them.
Yeah.
I guess, my question is, are you going down a road that says, even though you're great, we're going to lessen dependence because we think we can be better or as good ourselves? Or is this a post 5 year goal? I'm a little confused why at the beginning you'd be talking about lessening dependence.
That's a great question. I would like to have less dependency from a technology perspective. I think for us to do the volume that we're doing today and the volume we can do in the future, because I believe that our contact center can take on more appointment work. We don't do all the appointments across ambulatory care. I'd like for us to take on more. I would like to transition the technology so that when we use a vendor for people resources, those resources are using our telephony platform, our quality platform, our artificial intelligence, because that puts us in control. Today, our little team is on our telephony, but we've got 300 vendors on our vendor platforms, our vendor quality. I have to ask for reports. I have to ask for call recordings. I want all of that to be in-house so we control that. And that's what I mean about taking the dependency away from the vendor from a technology perspective. I think given our situation, giving cost, giving what it takes to manage a contact center with 300 people, it's in our best interest to have a vendor partner for people resources.
Yes.
Mhm.
You know, I want to use artificial intelligence. I want to have chat. I want to talk to our patients in the way they want to talk to us. But I want very much for us to have and maintain the human component for those patients who need to speak to a person, whether it's a language, whether it's an understanding. But folks who want to self-serve, I want them to self-serve, have a great experience, and be on their way. So from a people perspective, I'd rather have a vendor handle the headache of onboarding, hiring, recruiting. I just like to say, give me more and do it now. You show me how you're doing it, right? I want to be the demanding one. And, have them meet that where my team is focused on performance, innovation, strategy, just technology. How are we making this best for our system? How are we making this cost effective without minimizing even a little bit the patient experience, the provider experience, and the practice experience? We are just as much a partner with the facilities, the practices. I specifically hired a person to be the facility liaison to meet with the facilities. We have such diverse workflows and the way that we schedule or the way that the practices would like us to schedule. Our agents need a workflow tool that's a decision tree to make sure that based on where this patient wants to go, who they're seeing, what type of visit it is, we don't make mistakes. And it's critical that we are in lockstep with the facilities because they are our source of truth. We have a directory every month that says, this is what you do for us, and this is how we want you to do it.
Thank you. So
Can I say I love you?
Go ahead. Thank you, Sally. I think that's
Any more?
that's really great. I think obviously it's like our front door, right? Our call center, so incredibly important. And the history is. Thank you, Sally, for asking the question. Is great to hear the progress we've made. And
yes, thank you, Sally, so much, because I am one of those patients, and this is some good stuff here. But I haven't called in a while. So, but I'll, hopefully I don't have to call, but if I have to call, I'll see. But it sounds good because I am definitely, especially last year, one of those patients that was holding and concerned, and oh my goodness. So I am so proud, kudos, and thank you, Sally, for those questions, because those are the questions. I just want to quickly hear something about all of this include the diversity you were talking about.
Yes, absolutely. Absolutely. Yeah. I mean, that's critical to us. That's critical to us. We know that, New York City is the greatest city in the world. And we have diversity, that's what makes us so great. And, it's critical for me and paramount to me and my team that every person who calls us has the same experience, regardless of language, knowledge, stature. I want every patient to have the same experience, and that is the best experience. And we may not be perfect, but we are going to push ourselves to be as good, as great.
We definitely believe that. Thank you. Michelle, do you have a quick question?
Yeah,
Just quick.
this is
Okay, great.
incredibly helpful.
Great.
Really, really powerful presentation. My question was actually about behavioral health, separate call line, and then curious if the 998 changes the landscape at all, or how you're thinking about that.
Today, we don't handle behavioral health calls. I know that it's something that a lot of our leaders and all of us think a lot about. I will say we're stepping our toe in it a little bit with Metropolitan. They're really struggling from a staffing perspective. And so while we won't be doing any appointments for them, we're going to at least start stepping in and answering some general calls, maybe some prescription refills, hours of operation, location. So we're taking a nice little dip into the pool, and we're working with that team right now to formulate. So that might be a model that we can, as we have the opportunity, take on. I want to handle it all.
Terrific. I think we're also going to have a more fuller discussion on this topic. You're doing a briefing for us next month. So thank you. I think we need to move on. Barbara, you have a quick question?
Okay. I can't help but feel that we have some sort of phenomenal University of HAC building up here. From what
To spread our knowledge.
Today. And given that, it needs a good structure to hang itself on, even though some pieces are diverse.
The learning,
look at
sharing the learning.
What is our best outcomes and outcome and stuff like that.
Great.
Yeah, thank you. Thank you very much for the presentation and responses. And I think I will now ask for a motion on the resolution. Okay, all those in favor?
Aye.
And any opposed? The motion carries. Thank you very much.
Thank you.
Thank you.
Moving on, we have Dr. Katz's report. This was emailed to you, and it's also included in the materials. I'm going to...
Right. I won't read every word, but I'll cover some of the highlights. I hope all of you, because we're integral to health and hospitals, feel pride at our work in taking care of asylum seekers. We are very proud of our sister agency, DSS, and has done a phenomenal job, but they can't do everything. They are already, taking care of 56,000 asylum seekers in addition to other homeless individuals. So we've gotten involved in order to be able to supplement those efforts. We are now taking care of 16,000 people in our centers. We've provided 26,000 vaccinations and enrolled 13,000 people into health insurance. And we are a city of immigrants, and we're proud to do this work. We're also proud that we issued an anti-racism and non-discrimination policy that really focused on structural racism. And I think that's incredibly important because many people approach the issue thinking, well, I'm not racist because my best friend is so-and-so, which has absolutely nothing to do with structural racism, right? Structural racism has to do with how our society is structured in ways that make it harder for everybody to receive the same benefits of society. And so we recognize that structural racism and the way in which society fosters racial discrimination through systems of housing, education, employment, criminal justice, and other institutional practices has been a significant factor in creating healthcare disparities in the U.S., as evidenced among indigenous peoples and populations of color. And these disparities include higher death rates, shorter lifespans, and poor outcomes in the face of chronic disease. And our statement really asks people to confront the instances that they see of structural racism, and asks that we all look to be for ways of being anti-racist and figure out ways to promote groups that have been historically not taken care of. We have been related to this. We were among America's most socially responsible healthcare providers. The Lown Institute's Index for Social Responsibility reviews 3,600 hospitals across the country. And as a health system, we ranked number 2 for health equity, 3 for pay equity, 5 for community benefits. Jacobi Hospital was ranked number 1 for avoiding overuse of test and medical procedures, and Metropolitan ranked at the top as America's most inclusive hospital. Bellevue is number 1 for New York State for community benefit. Harlem Hospital's in the top 5 in New York State for social responsibility. Lincoln, top 5 for health equity. Queens, top 5 for racial inclusivity. South Brooklyn, number 1 for pay equity. And all our hospitals earned an A grade in at least one category. So we are very proud of that.
Very good.
Thank you. We expanded our behavioral health workforce with 50 peer academy graduates. We believe very much that peers through lived experience have a lot to offer in our health system. We're proud of these 50 graduates and look forward to their contributions to health and hospitals. I was with the mayor and our Deputy Mayor Williams Isom over at Rikers for a special event. Our correctional health service teamed to provide free smartphones to vulnerable New Yorkers leaving Rikers, so that the smartphones would enable us to be able for the person to be able to contact all their healthcare providers, and we'd be able to contact them if they missed visits, so that a very vulnerable group of people would be cared for on their departure. And it's very clever the way they, correctional health, put the specific trailer in the path that the person would follow after they left Rikers. So you can't leave Rikers without going by and recognizing that people leaving Rikers would want to leave quickly.
Yeah.
There's a service window, right? You don't even have to go in, right? You can stop at the service window that you have to pass anyway and get your phone or, you know, other kinds of things to prevent overdose. So they really considered, you know, their population and what would be needed. We've expanded our street health outreach and wellness program to serve unsheltered Queens residents. It's been a very successful program. We were recognized by the American Heart Association for our quality of care. Jacobi expanded its comprehensive addictions center. South Brooklyn received a prestigious nursing award. The South Brooklyn also reached a milestone of 20,000 births through its health midwifery program. I will provide you a finance update that the last finance committee was held on July 10th, where we looked at our financial highlights. The system closed June with approximately 30 days of cash on hand. We had a negative net budget variance of $200 million, but that's only 1.4% variance. Our revenue base remains strong. We have a large returning volume, and we have improved our collections. So overall, our strategic financial initiatives remain on track, generating $655 million through April of fiscal year 23, with a line of sight that meets our target of $675 million. In terms of community updates, both the House and Senate continue to discuss site-neutral policies that could negatively impact hospitals. Congress is also considering workforce investments, delaying the DSH cuts slated for later this year. but these cannot be paired with cuts to our hospital. Our system continues to advocate with our congressional delegation, and they've been incredibly responsive. The state, few workforce-related bills that our health system has been signed into law, including a bill that modernizes the restricted clinical laboratory license bill to allow individuals holding the license to perform all molecular tests, and a bill that expands the use of certain non-patient specific standing orders that registered nurses can administer. We want to thank Assemblywoman Lily Rosick for securing $1 million in state funds to upgrade the HUG's infant security and protection system at Queens. At the city level, the mayor and city council agreed on the fiscal year 24 budget on June 29th. It's $107 billion as part of our budget. Our health system received $80.6 million in capital awards, which breaks down as $59.6 million from city council, $3.2 million from borough president, $2 million in mayoral funding, and another $15.8 million from borough president. We hosted our Marjorie Matthews Awards. Several of you were there. Thank you, Barbara, for coming. Thank you, Jackie, for coming. It was a fun event. It was really nice to be able to honor our community advisory boards and our auxiliaries that do so much to support us. I ask your patience because I need to read for the public record the contracts that we've taken action on. So an extension of the food service contract with LICCOM LLC through December 11, 2023, amount not to exceed $217,055.60. An extension of the food services contract with Rethink Food New York City through August 1, 2023, an amount not to exceed $138,337,296. An amendment of the medical triage services contract with Rapid Reliable Testing to expand the scope of work to include social casework services and CDI and ASL translation services, as well as to extend the term of the contract through March 26, 2024 for an amount not to exceed $310,586,338. To house single adult male migrant asylum seekers for the rental of 320 West 31st Street for 1 year from June 7, 2023 to June 6, 2024 for an amount not to exceed $8,213,700. To house single adult male migrant asylum seekers, the rental of 3711 35th Avenue, Astoria for 1 year from May 17, 2023 to May 16, 2024 for an amount not to exceed $1015155. A renewal of our existing lease of the Stewart Hotel to house the families of migrant asylum seekers for 3 years through June 6, 2026. But the agreement may not be terminated, but the agreement may be terminated on or after December 6, 2024 for costs not to exceed $158,070,221. To house the families of migrant asylum seekers, the rental of dorms owned by the American Musical and Dramatic Arts School on 117 West 70th Street, 205-207 West 85th Street, sometimes known as the Stratford, for 3 years from June 12, 2023 to May 31, 2026, but the agreement may be terminated on or after June 11, 2025 for an amount not to exceed $109,010,880. House the facility of migrant asylum seekers, the rental of dorms located at 7060 3rd Avenue for 11 months from June 27, 2023 to April 30th, 2024 for an amount not to exceed $3190,062. As single adult male asylum seekers, the rental of 47 Hall Street, Brooklyn for a period of 18 months commencing upon the completion certain construction at the property projected to occur September 15, 2023, which would put the expiration of the lease at approximately March 14, 2025, for an amount not to exceed approximately 45 million. This project has the potential to include more floor area to be as long as 7 years, but the expansion or extension are required to be coupled with the takeover of the project from H&H by DCAS to house the families of migrant asylum seekers, the rental to Crown Plaza, JFK Hotel for 3 years, provided that the agreement may be terminated after 1 year for an amount not to exceed 72,659,916. Nice opportunity for me to thank in front of all of you, Jeremy. All of these contracts Jeremy has written. He doesn't just sit in for Andy when she's not here to be our general counselor, but these contracts are a huge amount of work. The city relies on us to be able to open these facilities quickly. People might say, well, but this has been going on for quite a while. Why is this still an emergency? But it is an emergency because people keep coming and there's no place. And it's a human need. If Jeremy was not able to write the lease agreements fast enough, people would be on the street. And there is literally no place. There is no place for our newest immigrants to live. So all of these contracts you can see are about our work with HERC. We certainly hope at some point this will become a regular established and not emergency provision, but we really are still on a day-to-day basis counting the number of new arrivals and trying to make sure that no one is living on the street and that families with children are being housed, especially in appropriate facilities for places with young children. So with that, I'll stop. Thank you.
Questions. One, it's great that you're doing an RFP on the HERCs. I think it's great that when we can take a breath and follow a process, it's a good thing to do. Two, the mayor announced that after 60 days, single men would have to leave the facility. What happens to them?
They would go to our Roosevelt Center, and they would essentially be processed again. In other words, the idea would be, okay, so after 60 days, you were not able to find family, you were not able to support yourself. What's the plan going forward? And the idea would be to be able to, at that point, provide a more maybe individualized or proactive answer to what are you going to do next?
A more rigorous screening at that point.
Right. I mean, again, globally, the people who are coming to work. They are not coming, to stay at our hotels. They are coming to work. But there are a variety of barriers to coming to work. Right. And sometimes we do find that people who thought it was going to be possible to find work in New York discover, no, it's not. And boy, New York is expensive. Mm-hmm. Right. I mean, we are a very expensive place to try to eke it out. And so sometimes what we find is that people at 60 days, if we're willing to help them to get to a relative that they have in another part of the country where it is not as expensive, are interested. So the idea is to say, and I think this comes directly out of, there's just not more places to rent. Right. We're really struggling on some of the places that we have used out of necessity, like school, gyms are really, they're not good settings, and they interrupt other programming. So the city is really, stuck. And so the idea is, make it clear that while other cities are saying, you're not welcome here, we're saying you are welcome. And we're going to provide you shelter and food for 60 days. And if at that time you still have not come up with a plan, we're going to meet with you again. and we're going to figure out with you what is the best plan, and that might then include housing them in another place, but not as an endless thing.
Okay, thank you.
Mr. Nolan.
Yeah, Mitch, if I may ask, it appears that as I'm reading through these, that these are all related to the migrant asylum seekers, as you said.
Correct.
And they appear to be emergency contracts that you had to enter into in between our meetings because you're authorized to do that as our president.
Correct.
Okay. And
Yes.
so you're presenting to us as quickly, as you said, as quickly as Jeremy can write.
Yes.
And pass muster and pass it on to you, then you would sign it because we have migrants coming offering 2,000 or 3,000 a day, and they need to have lodging, they need to have food, they need to have other services that they need to receive. So then you enter as the president of our corporation, the Health and Hospitals, so that these contracts can be approved and the services can be delivered.
Perfect. And I think in part of the public process is this is the board's opportunity to say, you know, we support this and, you know, we understand, or, you know, we don't want to be doing this. But all of the feedback that I've gotten in these contracts is that the board supports our doing it. It's also a good time to point out that the costs are not borne by the health system. Right. That was an important when we got into this business. We said we don't want to take money that would have otherwise gone for hospital services or outpatient services, lab tests, medicines to do this function. But we're prepared to do it again because our very capable sister agency can only do so much so fast, and we didn't want people on the street.
And I think you do note here that you're undergoing a process and diligence and all of the things that we typically would do if you had more time.
Correct. And I also important to note on the Hall Street one. Sometimes we're entering with the city with a specific agreement that we're going to do the initial lease in part because of Jeremy's competence at getting these done quickly, but that we want the lease to move to another agency, in this case, DCAS, which we think is the capable group to hold the lease, but they could not, under their procedures, get it done as quickly as we could. So we enter into it, and then the lease moves to them. And since the city is paying, it's a non-issue financially. But I felt, especially for the Hall Street property, that it was most appropriate for DCAS to ultimately hold it. If they would have been able, if their processes would have allowed them to do it in a timely way, it wouldn't have been on our list. But again, I don't see any harm. We're not incurring the dollars, and the agreement is clear that DCAS will take it over when they can.
Any other questions or comments? Thank you, Mitch.
Thank
as always, a lot of terrific work, and thank you for highlighting it. On the committee reports, they were emailed to you and are in your folders for your review for the NPA and Finance Committee. Submitted into the record. Are there any questions or comments on those reports? Is there any other old or new business to come before this board? Hearing none, the board meeting is adjourned. Thank you.
Yay, good job.
Thank you.